We're going to talk today about the science behind light-accelerated orthodontics. I'm Dr. Peter Braun, the co-founder and chief scientific officer for Biolux Research Limited. We're based in Vancouver, BC. So I'm going to just preface things by saying these opinions are not necessarily those of Biolux Research, but they're my personal opinions. We're going to talk today about photobiomodulation. Photobiomodulation is the ability for cells to convert light energy into chemical energy. And this premise, it seems quite unusual to some people, but most life on the planet is plant life, and plant life derives its energy from the sun. And over billions of years, plants have been very effective at taking electromagnetic energy and turning it into chemical energy. So there's still that ancient ability in our mitochondria. There's certain enzymes and compounds in the mitochondria that are responsive to light and can generate ATP as a function of absorbing light. So essentially, photobiomodulation uses light in the red to near infrared range, 600 to 1,000 nanometers. This can be generated using low energy lasers, light emitting diodes, a variety of different light producing semiconductors and devices. And photobiomodulation has been shown to increase mitochondrial metabolism, facilitate wound healing, promote angiogenesis, bone, nerve, and skeletal muscle repair. Over 5,000 peer-reviewed articles in the literature on photobiomodulation, the majority using low-level lasers to produce the light. And the orthopulse uses light at 850 nanometers, which is in the near infrared, which is essentially virtually invisible to the human eye. Now, the reason we use 850 is because there's an optical window between 600 and 1200 nanometers where we get the least absorption by hemoglobin, oxyhemoglobin, water, melanin. So we get maximum penetration through tissue. So if we're just treating the surface of skin, it's not really an issue and you can use different wavelengths. But when we're trying to get light through gingival tissue and bone marrow, we want to get as maximum penetration as possible. And Stolik found in his ex vivo biopsy tissue study that of the four wavelengths that they evaluated, the highest 835 nanometers had the most penetration in tissue. So Nobel Prize was given to Otto Warburg in 1931. He determined that mitochondria, and specifically cytochrome C oxidase, which is an enzyme in the electron transport chain, was responsive to light. So we have some, really 80-some-year-old evidence showing that mitochondria respond to light. Professor Mester, who was considered to be the father of photobiomodulation in Budapest, wanted to see if laser radiation would cause cancer in mice. So he shaved the dorsal hair, divided them into two groups of mice, gave laser treatment at 694 nanometers to one group and not to the other group, the control group. Found that there was no cancer being generated, and to his surprise, the hair on the treated group grew back more quickly than the untreated. So showing that there was a distinct biological response to the application of that wavelength of light. So that gave birth to the field of photobiomodulation. So there's three known mechanisms. Number one is the absorption of photons by mitochondrial chromophores, and these are enzymes and compounds that absorb light. This leads to ATP production, ATP being the energy currency in the cell, and cells, whether they're osteoclasts, osteoblasts, endothelial cells, require ATP to function. And number two, we've got an increase in reactive oxygen species. So this is involved in mitochondrial energy production and there's signaling that occurs between the mitochondria and the nucleus. And so what ends up happening is we end up increasing DNA and RNA synthesis, and we get a plethora of tissue and cellular activity as a function of that communication. And number 3, we've got nitric oxide production. So light can be absorbed by nitric oxide synthase and produce nitric oxide, which can lead to increased blood flow and can actually stimulate osteoclastic activity as well. So here we have mitochondria, and normally we have electron transport chain oxidizing substrate, which could be sugars or fats, and as a process of that electron transport chain oxidation, we pump protons into the intramembrane compartment of the mitochondria. And there's a proton concentration gradient that allows ATP to be produced. So if we have normal cellular activity, normal oxidation, normal blood flow, we get normal ATP production and cells function normally. When stress is applied to a cell, and we can imagine an orthodontic force on teeth roots and periodontium is stress and decreases blood flow. And in some extreme cases, we can actually have cell death, hyalinization, and also the resorption of bone, causing root resorption over time. So by applying light to the mitochondria, in the situations of stress, we can overcome this decreased oxidative activity, which leads to less ATP production. So stress on the tissue, stress on the cells, decreased blood flow, decreased oxidation, electron transport activity, decreased proton pumping, decreased ATP. So now we have these cells, whether they be fibroblasts or osteoblasts, are functioning at a lower level than normal. By applying light, and absorption of light leads to the increased pumping of protons. And that increased pumping of protons generates more ATP production. And we have more ATP, so therefore we have more ability of the cell to function normally. So we're restoring function in areas where there's stress. So we've got some animal studies showing that we actually can decrease root resorption by the application of light because we're adding energy to the system and we have greater cell viability. So here's a very elegant experiment where human neurons were grown in tissue culture and treated with 1 dose of laser light at 808 nanometers. ATP was measured prior to the application of light and then at 10 minutes after the application. What we found was roughly a 2-fold increase in ATP production with 1 photobiomodulation treatment. Photobiomodulation leads to a number of cellular activities, proliferation and differentiation of osteoblasts, activity, and bone formation. We also see all of the precursors of bone formation, collagen metabolism, fibroblast activity, and procollagen synthesis is increased with photobiomodulation. We're stimulating the formation of osteoclast-like cells via rank and rankle. We're proliferating and differentiating osteoclasts. So we essentially applying light to the orthodontic tooth movement biology. We're just simply enhancing the activity that would normally be progressing. So it's not a hyperstimulation, it's more of an enhancement and a restoration of normal cellular activity, which of course will lead to faster bone remodeling and faster tooth movement. So there are some practical applications already in the field of dentistry and medicine. Lasers used to treat hypersensitivity of teeth in dentistry, stability of implants, and in medicine we've got different devices to increase wound healing, decrease inflammation, and FDA approval for the treatment of hair loss. Chiropractic, dermatology, ophthalmology, we have a variety of devices used primarily to enhance healing and decrease pain. So we've got a lot of articles in the literature in animal models demonstrating the effect of photobiomodulation on orthodontic tooth movement. We see an acceleration of the velocity of tooth movement, increased expression of collagen formation, and both in rats and in rabbits. There's some human clinical trials using laser, primarily looking at distalizing canines. We see anywhere from a 30% to a 100% increase in the rate of tooth movement of photobiomodulation treated canines versus control. So we're going to talk a little bit about OrthoPulse. So OrthoPulse uses light-emitting diodes, an array of light-emitting diodes, to produce a uniform exposure of light into the alveolus. Silicone, medical-grade, implantable-grade silicone mouthpiece embedded with LEDs, and then a very sophisticated microcontroller, and then wireless Bluetooth compliance monitoring, as well as wireless charging of the battery. So patients would treat e-charge for 5 minutes once per day. We work with a lot of outstanding institutions around the world. Orthodontic research, if we're going to make claims of accelerated tooth movement and reduction of treatment times, we need to have very good scientific and clinical evidence. So since 2003, there's been more than 30 OrthoPulse published clinical trials, in vivo and in vitro studies. More than 400 patients have been treated in clinical trials worldwide. So we'll just review some of the OrthoPulse in vitro evidence. So this is cellular evidence. So Steve Yan at USC and his team there showed that OrthoPulse wavelengths stimulated a wide variety of gene expression in human cells. So using gene arrays, we're able to measure twofold and higher stimulation of genetic activity, and also inhibition of genetic activity. So we have a direct link to gene activity and photobiomodulation with OrthoPulse. We see we've got increased proliferation of gingival fibroblasts and endothelial cells. So photobiomodulation is not only going to restore and enhance heart tissue, bone remodeling, but we see that it has a profound influence on gingival remodeling and formation of blood vessels. In addition, we see proliferation and mineralization of human osteoblasts at 850 nanometers. And we also see that we can modulate the inflammatory response in the PDL due to orthodontic tooth forces. Some of the in vivo evidence performed at Boston University, University of Vienna, and Forsyth Institute in Cambridge, Massachusetts, show that using light on an animal model, it's a well-proven animal model used in evaluating the physiology of wilchodontics, corticotomy, assisted orthodontic treatment. We saw an average of 3.3-fold increase in the rate of tooth movement. And if we look at the infrared short protocol, the green bar, we see that we have almost a 4-fold increase in the rate of tooth movement versus the TM group, which is the group of animals that simply had traction on the upper first molar with a Naitai spring with no application of light. So we can see that we can get a profound influence on the rate of tooth movement in this animal model, well-proven animal model. So additional in vivo evidence. We also saw 80% less root resorption in animals treated with 620 nanometer light. So the thing to remember is each wavelength of light has some unique properties as far as penetration and absorption. but we generally will tend to see similar outcomes across the spectrum of light. We saw more bone, more mature bone and expanded sutures in orthopedically expanded sutures in rats. And we also found there was a significantly lower failure of immediately loaded orthodontic TADs. So we can see that we're enhancing the biology and preventing inflammation and loss of bone around TADs. So in our fixed appliance clinical studies, we found no clinically significant root resorption. And in a randomized controlled trial, where we were looking at space closure and en masse retraction, we found a 46% increase in the rate of space closure in the Samara study. And Shaughnessy found a 54% reduction in time to achieve anterior alignment compared to controls with fixed appliances. It increased the average rate of tooth movement almost threefold during the alignment phase. People ask, well, patients must get tired of doing orthopulse treatment, and so you get diminishing effects over time. And we found in the Shaughnessy study that average compliance over 6 months was about 86% and above 80% after 1 year. So we find that patients are very compliant. Recently published article in the JCO by Dr. Shaughnessy found a reduction in number of appointments and a reduction in overall treatment time when using orthopulse in conjunction with fixed appliances. Some clinical evidence looking at pain in our randomized controlled trial currently underway. This is a sham-controlled study where we found that the orthopulse group had approximately half the level of pain compared to the sham control group. We have patients comment and remark on how doing orthopulse treatment feels more comfortable and they have less perception of pain, especially if there was a period where patients weren't able to do their treatment or went away for a weekend and remarked when they came home that they couldn't wait to do the orthopulse treatment as a result of having a few days without it and having significantly higher discomfort. So we've also got some clinical research associated with aligners. So in the Dickerson study, we found a 63% reduction in the average time per aligner compared to the conventionally recommended aligner wear time. And in 6 months, we found no measurable root resorption. So teeth are only moving quicker because the bone is remodeling faster. We're not applying higher forces to the teeth. So we're using the same forces, the teeth are moving faster, and we're sequencing through aligners more quickly. So in this pilot study, we saw that we were able to reduce aligner switching rates by 66% with the 10 minutes of orthopulse treatment per day. Now we also looked at 20 minutes per day to see whether that would enhance the rate of tooth movement, and we found really a non-significant difference of 3%. So 10 minutes per day is really an optimum. Doing additional treatments doesn't provide any greater value for the average patient. So just to recap, photobiomodulation increases energy production, which is ATP production in stress cells and tissue. It accelerates bone and soft tissue remodeling. It's nonspecific. All cells and tissues benefit. Any cell that has mitochondria works with any orthodontic system. So basically, the doctor does not need to change their clinical technique. There might be some optimization through the use of modified mechanics and protocols. So we know that teeth align more quickly with fixed appliances in the alignment phase. So wire selection may need to be modified, or the patient may need to be seen more frequently for the first wire change because the teeth align so quickly and you want to keep light continuous forces on the teeth to maintain tooth movement. It's a non-invasive, drug-free, and extremely low risk profile. It's a class 2 device. And the scientific mechanism is well understood, and the literature is replete with in vitro, in vivo, and human clinical studies showing efficacy. Thank you very much for listening. Please go to orthopulse.com to our clinical evidence page where we have all the up-to-date research. You can download our clinical and scientific dossier for more details. Thanks very much for listening. I appreciate your time. Thank you.